Assalamu alaikum. I am Dr. Ejaz Mohiuddin. Today's topic is renal stones. So we are going to discuss the etiology, signs, symptoms, investigations, and treatment of the renal stones. Etiology. Multiple etiologies. Number one factor is the dietetic factor. Deficiency of vitamin A causes desquamation of the epithelium, which forms a nidus for the stone formation, and around this nidus layers accumulate and a stone is formed, which may increase in size. Number two is altered urinary solutes and colloids. In dehydration, solutes increase to form the stones. So as the solvent would decrease, solutes increase, solutes get accumulated, get together and form the stone. Number three is decreased urinary citrate. Presence of citrate in urine 300 to 900 milligram per 24 hours keep insoluble calcium phosphate in solution, but decreased urinary citrate causes the insoluble calcium phosphate to become soluble and form stones. Renal infection, they again form urinary stones. Then urinary stasis. Urinary stasis, as in case of bedridden patients, paraplegia, or CVA patients, where the patient is unable to move from its bed. Urinary stasis causes stone formation. Then prolonged immobilization again causes skeletal decalcification, increased urinary calcium forming stones. As I said, patients who are on bed for a long time because of any cause of immobilization, they may develop renal stones. Hyperparathyroidism leads to hypercalcemia and calcium and stone formation. Hyperparathyroid serum from the bones, the calcium is getting out and it comes into the blood, and from the blood when it goes into the kidneys, they form stone formation over there, hypercalcemia. Types of renal stones. So the number one type is oxalate stones. These are irregular with sharp projections, hard and very opaque. Because of these sharp projections, they are early to diagnose because they are painful, and blood the blood comes in urine in early stages. Number two is phosphate stones. Smooth, dirty white, grow in alkaline urine, especially when urea splitting bacteria, example Proteus, is present. It forms staghorn stones, cause hematuria and renal failure. Staghorn stones are those stones which take the form of the calyces, and they are difficult to be removed. Number three, uric acid stones, hard, smooth, multifaceted, radiolucent stones. It show filling defect in the X-ray. Radiolucent, which are not visible on normal X-rays. Cystine stones, uncommon congenital error of metabolism leading to cystinuria, hard, multiple, and radiopaque. Clinical features common in the age group of 30 to 50 years. Male to female ratio is 4:3, that is more in males. Silent or produce renal failure or infection, visible in plain X-ray KUB. Kidney with a bladder may be radiopaque or radiolucent. Pain. It is present in 75% of the cases. Fixed renal pain in the renal angle, hypochondrium, or both. Words on movement. Ureteric colic is an agonizing pain radiating from the loin to the groin, the penis, the scrotum, labia majora, or front of the thigh. Pain may last from 1 to 8 hours. There is no pyrexia. Pain occurs when stone moves downwards. As the stone leaves its place and tries to move out or downwards, it causes severe pain. Hematuria is common because of abrasion of the smooth structures. On abdominal examination, there is tenderness, rigidity, percussion, doubt is dull. Urine exam shows pyuria, hematuria, cast. Then, if septicemia occurs, it is dangerous. Investigations. The first and foremost is the urine DR and the urine DR and CS. So urine DR shows red cells, pus cells, cast, crystals, and culture insensitivity shows to which antibiotics the bacteria is sensitive, what bacteria is present, and to which antibiotic it is sensitive or resistant or insensible. X-ray KUB, radiology. X-ray KUB would show in the first instance how many stones are present, what is the size of the stone, in which side it is present, and is it number one. Number two, sometimes it is not shown in the X-ray KUB. That may be because of uric acid stones. Then that is shown in the intravenous urogram or intravenous pyelogram. Ultrasound scan, CT scan or MRI. Then intravenous urogram to see those stones which are not shown in the X-ray KUB. Secondly, to see the function of the kidneys, whether the kidneys are functioning or not. It is very necessary to know this function of the kidneys in case of before going to surgery. Extracorporeal shockwave lithotripsy, again this is an ultrasound, and it is investigation as well as the treatment. Treatment, conservative methods. Conservative methods includes drugs which are going to produce more urine, and small stones. If the stone size is less than 0.5 centimeter, it may pass through the kidneys and the urine along with the urine. And if the stone is more than 0.5 centimeter, it may obstruct a calyx or become focus of infection. Antibiotic pre and post operatively will have to be given after surgery for the renal stones, and the surgery done is open operation for minimal access techniques. Renal stones, modern methods of stone removal. Kidney stones, percutaneous nephrolithotomy. Endoscopic instruments are passed into the kidney by percutaneous technique, and nephrostomy drain is left behind. By this method, stones are broken, removed, and for the diuresis, that drain is put, so that any blood that may come out from this drain. Extracorporeal shock wave lithotripsy. In this also, ultrasound waves are passed, stone broken, and it is diuresis given, and through this method sometimes a stent is placed in it so that any small pieces which may be left behind may pass through it. Open surgery, pyelolithotomy or extended pyelolithotomy, and other surgeries options are partial nephrectomy and total nephrectomy. In both cases, partial and total nephrectomy, severe hemorrhage may be possible, so always we have to arrange blood before going for surgery, and that blood may have to be transfused during or after operation. Treatment for bilateral kidney stones: in case both kidneys have stones, then the kidney with a better function is treated first. Better function is seen with X-ray IVP. The kidney which shows the dyes first is the better function kidney. Number two, if pyonephrosis is there, then that kidney is treated first, because there is a chance that that kidney may die immediately. So in order to try to save it, we do these operations on it first. Reference is Short Practice of Surgery by Bill and Love, 26th edition. Thank you. I hope you would be clear in this presentation about the kidney stones. The following presentation, the next presentation would be about the urinary stones. They are interconnected, so we would be doing it simultaneously. Thank you.